Hey everybody, I'm very excited to be doing my second literature review today. Today I will be reviewing Advances in Lymphedema. This is a brand new publication from Dr. Stanley Rockson, which was published in Circulation Research just last month, June of 2021. This is a really great publication for patients, therapists, caregivers alike to learn a little bit more about the advances and the explosion of advancements we've seen in the past decade. So the very first sentence is really interesting where Dr. Rockson says lymphedema is a common, complex, and inexplicably underappreciated human disease. So he goes into a lot of different things that have been identified in the past decade. And the very first thing he mentions is the study of genetics. Now, there's a long bit of information here, but I'm going to just say that at present, there are 28 known genes that might harbor causal mutations for primary lymphedema. So being able to identify these genes in patients who have been told for so long that there's nothing wrong with them or nothing that the doctors can find will really help patients identify that there is in fact a problem. And the hope is that, as Dr. Rockson says, an optimistic yet realistic expectation might be that careful analysis will soon lead to the development of novel and targeted therapies for these patients with gene mutations. So there's still a lot of research to be done, but we are well on our way. The next category of information in this publication is on imaging. So we're going to review a few different types of imaging that are still very common in the diagnosis and for potential treatment for lymphedema. So the first one is lymphoscintigraphy, and lymphoscintigraphy is still known as the gold standard for diagnosis. It is injecting the lymph vessels with a dye to look at lymphatic transport function. So how is the lymphatic fluid moving through the vessels? Where does it stop? Where is there a blockage? And what can we do moving forward to help this patient get better? The next type of imaging is called near infrared lymphography. It's also known as Endocyanine green testing, which is a little bit newer in the lymphedema world. So this is looking at the superficial lymphatic anatomy and where you might see nice lymphatic pathways through the vessels that are working optimally. There eventually is a backflow or cloudiness where we can see that the lymphatics are no longer working effectively and the lymph fluid is backing up into the tissue surrounding the area underneath the skin. So this technique has become very popular in helping with determine the severity of the disease and also in helping to determine surgical interventions. So this is also very important for patients who have secondary lymphedemas to find exactly where down the line, particularly in breast cancer patients, the biggest backup is. Magnetic resonance lymphography, MRs, with or without contrast, they have proven particularly useful in the perioperative evaluation for lymphatic microsurgery. So again, helping with surgical intervention. This also has better imaging depth limits versus some of the other more superficial imaging. And lastly, high frequency ultrasound is used to detect dermal thickening. So if you have fibrosis, just how affected is your superficial skin and tissue? The dermal thickening is something that happens over time. Is this patient suffering more from a lymphedema or a lipedema? Ultrasound is better able to assess this and help doctors determine a diagnosis. Now I want to talk briefly about lymphatic surgery, and it is divided into three broad categories. So procedures designed to reduce the likelihood of lymphedema, number two, debulking operations, and number three, microsurgical interventions to correct impaired lymphatic systems. So to go over these very briefly and very quickly, first we're looking at ARM, axillary reverse mapping. So this is a pre-surgical technique that is designed to protect lymphatic function during an oncology procedure, specifically in breast cancer patients. So it's performed at the time of lymph node dissection. It is hoped to reduce the likelihood of same side arm lymphedema through the creation of a lymphatic to vein anastomosis. Additionally, there is a technique called surgical volume reduction, or SAPL, S-A-P-L, suction assisted protein lipectomy. This is also known as that debulking technique, and this is to help patients who have significant fibrosis, thickening of the dermal tissue, changing of fluid to an adipose tissue or fatty component. It helps reduce that fatty tissue or eliminate that fatty tissue to create more of a fluid volume improvement. Compression is still required after this type of surgical intervention. And the final category is the microsurgical interventions. There are LVAs, or lymphovenous anastomosis, VLNT, vascularized lymph node transfer, and a combination of the two. I'm not going to go into the details of these surgeries in this review. Please let me know if you'd like to know more. But a very skilled microsurgeon will determine, is it best to connect impaired lymph vessels to better working lymph vessels, to nearby venous structures, or to actually move and transfer lymph nodes from one area of the body to another. So there is further discussion on how surgical interventions are determined and decided by the physicians and their teams. There is a little bit of information on long-term inflammatory processes, stem cell therapies, as well as the role of chronic inflammation. There are a lot of human trials that still need to be done to determine what causational factors there may be. There is currently a drug on the market called ketoprofen that may be appropriate for certain patient populations in reducing inflammation due to lymphedema. Dr. Rockson goes into this a little bit in this paper, but in much more depth in another paper. And then finally, he goes into talking about fibrosis and the relation with inflammation and how that can better be treated with therapeutic intervention and with potential medication intervention. He also discusses the link between obesity and lymphedema. So obesity has long been identified as a potential risk factor for lymphedema, but he goes further into saying that in addition to adipose hypertrophy, so inflammation or hypergrowth of the adipose tissue, fatty tissue, resulting inflammation can cause further fibrosis. So it's a vicious cycle. One will affect the other, and so on, causing worsening of both conditions. So this leads us to the end of the discussion, talking about lymphatic diseases and their comorbidities. And this just goes on further to say that a relationship between the presence of disease and the loss of lymphatic functional integrity is a real thing. A large and ever-expanding list of pathological states is now associated with the presence of abnormal structure or function of lymphatic circulation, either regionally or systemically. So he acknowledges that we have come a very long way. We now know a lot more than we used to, and we're coming up with novel ideas to research and to hopefully treat better in the future. I hope this has been helpful. Please again, let me know if you have any questions. Thanks.